Excellent. Good morning, everyone. This is welcome to the next edition of the Nephrology Grand Rounds. Today, we are really excited to have Professor Adnan Sharif from Birmingham, UK, present to us on cardiovascular management in transplant patients. He's trained in Edinburgh, Cardiff, and Birmingham, and has been a consultant transplant nephrologist and an honorary professor at the University of Birmingham for over a decade. Professor Sharif has almost 200 peer-reviewed publications. He's had several leadership roles in the British Transplant Society as well as the European societies in mostly in transplant-related fields. He really has been one of the foremost voices, in my opinion, on the whole cardiovascular management pre-transplant in our dialysis patients. So we are really excited to have you here.
Cool. Thank you, Sop, and it's a real pleasure to be joining you. So I'll just skip through the disclosure slide. So I thought what I'll do is some of you may not be familiar with Birmingham, where I currently work, so I thought I'll kind of give you a little snapshot of the city, which is the second biggest city in the UK. So it was actually the birthplace of the Industrial Revolution in the mid 18th century. So a lot of the legacy in the city reflects the fact that this was the centerpiece for that. And one of the legacies from that was the extensive canal network that was built around Birmingham. And people, whenever they think of European cities and lovely canals, they always think about Venice. But I've checked this on numerous occasions. We actually do have more miles or kilometers of canals than Venice in Birmingham. We are also obviously the home of the best chocolate in the world, Cadbury. Although the ownership has moved around the world, we still consider Cadbury to be proudly British and proudly from Birmingham. I never used to show this slide before because it used to be too embarrassing. But now Aston Villa is flying high in the Premier League and in the Champions League, so we now can kind of proudly show Aston Villa. And of course, it was the birthplace of heavy metal. This, as I'm sure you know, is Black Sabbath, which was fronted by arguably Birmingham's favorite son, Ozzy Osbourne. Although these days, I guess Thomas Shelby is probably the fictional favorite son for Birmingham. And if you haven't seen Peaky Blinders, I would strongly recommend it. And they're currently filming the movie in Birmingham as we speak. So this is the overview of what I'm going to talk through when it comes to cardiovascular management. I'll give you a little bit of background, which I'm sure will be familiar to all of you. So I'm not going to spend too much time focusing on that. But then I'm going to talk about the post-transplant management of cardiovascular disease in a kidney transplant patients, and then focus a little bit on my pet hobby horse, which is the pre-transplant cardiovascular management, very specifically the cardiovascular workup that we do for kidney transplant candidates. And then end with a little kind of just a philosophical point on how I see things when it comes to transplantation and how best to improve management of our kidney failure patients. So, I mean, I'm sure we're all familiar with the range of cardiovascular complications that we see in our patients, and we see a lot of cardiovascular complications because we know that in the context of worsening kidney disease and kidney failure, we see a lot of structural and functional changes in the heart. And we also know that as people progress through the different stages of chronic kidney disease and when they hit kidney failure, the cardiovascular disease burden rises. And some of that is due to atherosclerotic events, but increasingly towards the end of their kidney disease journey, it's more non-atherosclerotic events due to those structural and functional changes. And we know that kidney failure is associated with a significant burden of cardiovascular events. But what we also know, and this is probably one of my main take-home messages, is we know that in the context of kidney failure, getting a successful working kidney transplant is perhaps the single best thing that we can do to lower the long-term cardiovascular burden for our patients. And one of my philosophies is that we should be thinking about transplantation as a cardiovascular lowering event for our kidney failure patients. But of course, cardiovascular disease does occur and does affect our kidney transplant patients. All of us will be using some kind of cocktail of these immune suppressants, whether it's induction or maintenance therapy. And as I'm sure we're all aware, all of them are associated with certain cardiometabolic risk factors. And so we do see a lot of major adverse cardiovascular events. And this was a piece of work that we did looking at MACE events in England. And you can see that in the first 12 months, and MACE was defined very broadly. So myocardial infarct, unstable angina, heart failure, strokes, anything that which led to a hospitalization. You can see that our rates are 1 year, we're about 2.6%, which is probably on a par, perhaps with yourselves and across most of Europe. In the US, they tend to be a lot higher for reasons I've never quite understood, but probably double, if not triple that. You can see our commonest MACE event in the first year is myocardial infarct, and you can also see that over half of those events happen very early within the first month of transplantation. I think one of the most important things from this slide, though, is that the amount of mortality associated with a MACE event is actually quite low. Only 11 earlier events within the first month, and only 28. So that's about 1 in 1,000 within the first year. That's not to say a non-fatal MACE event is a completely benign event. The same work that we did, we looked at long-term patient survival, and you can see that people who have a non-fatal MACE event in the red line do have inferior long-term survival. And if you look at long-term causes of death, this is data from the UK Renal Registry looking specifically at kidney transplant patients. You can see that blip because of the pandemic where infection suddenly became the leading cause of death. But cardiovascular disease has always been in the top 3. Perhaps from 2017, the line seems to be going down the way, but there is a caveat to this data that about 40% of the causes of death are missing in this data. And I imagine a lot of that will probably be cardiovascular disease. So I think in most countries, cardiovascular disease is either number 1 or perhaps just being pipped ahead by malignancy as a number 2 cause of death. So how do we manage cardiovascular disease complications after kidney transplantation? So there are some guidelines out there, and there are some international guidelines, and for us in the UK, we have guidelines between the UK Kidney Association and the British Transplantation Society, and you may have some national guidelines in Canada as well. But the difficulty is that the evidence base for most of those guidelines is quite weak. And it's weak because we don't actually have very many trials in transplantation where we are focusing on cardiovascular outcomes. So we have some trials looking at the use of statins, folic acid, or ACE inhibitors, whether cardiovascular disease was a primary or secondary outcome. And sadly, most of these, when it comes to a cardiovascular point of view, had negative outcomes. This is the viewpoint from the American Society of Transplantation with regards to the targets and the metrics that we should be using. And I think it's difficult to argue with most of these measures, and most of us are probably following something like this. But even if you consider in the third box under diabetes, using low dose aspirin, the evidence base for the use of aspirin to prevent MACE after transplantation is again very weak. This is a meta-analysis of just 3 studies, which suggests that aspirin does prevent MACE, but none of these are randomized controlled trials. And you can see the very heavy weighting from Helen Pilmore's study. So again, many of us will do this, but the evidence base is not very robust. And I think what we really need to be focusing on is to achieve those treatment targets. So most guidelines suggest that we should be targeting a blood pressure of 130/80 or perhaps even lower in the context of proteinuria. But if you look at the UK and if you look at our registry data, the number of our prevalent kidney transplant patients who achieve that target blood pressure, that's actually only achieved in about 55% of our patients. For those with a GFR less than 30, who you could argue have an even higher cardiovascular risk, we're even worse are achieving that target we're at 45%. So we have the antihypertensive medications available. We are not very good at hitting those targets. And some of this may be because perhaps we lag behind the general population with regards to use and adoption of some of these cardiovascular disease-lowering therapies. This is a very old study from Helen Pillmore, and I would hope that our figure on the right is much better with regards to our use of some of these therapies. But I would argue that perhaps many of our patients are not getting the cardiovascular disease-lowering therapies as their counterpart would be in the general population. And one example of that is the use of SGLT2 inhibitors and the use of GLP-1 receptor agonists. And I think this article, which was published in Circulation, really hit the nail on the head when they said that these drugs should be we should repackage these drugs and think about them as cardiovascular and kidney disease risk reducing agents with a side effect of glucose lowering for some of these therapies. And there's been lots of discussion and lots of debate about these therapies and about their use. And I think there's a lot of heterogeneous practice. There are some individuals or some centers where they are early adopters and they're using these therapies for their patients, whether they have diabetes or they don't have diabetes. But there are other areas and other centers where there aren't many patients on these therapies. And I've had an interest in post-transplant diabetes for 2 decades now. That was what my PhD was in and what got me interested in not just transplantation, but post-transplant complications. And earlier this year, we published a consensus document. So this was not looking at the evidence base per se. This was more based on expert opinion. And what we strongly advised was that we should start using these new novel therapies in the absence of long-term cardiovascular outcome data in transplantation. And the reason for that is a kind of a heat map like this, which comes from the general population. So this was a systematic review and meta-analysis looking at the benefits and harms of drug treatment for type 2 diabetes in the general population. And to summarize this heat map, you can see that it's only these novel therapies, it's SGLT2 inhibitors and the GLP-1 receptor agonists that actually have cardiorenal benefits. Everything else don't. They may lower glucose levels, but they don't really have the same cardiorenal benefit. And some therapies like the sulfonylureas, which are still commonly used by people post-transplantation, may actually be associated with some cardiovascular harm. And one of the reasons why there is a reluctance is because we don't have the same level of data as the general population. And of course, we know our transplant patients will always be excluded from these major studies looking at cardiovascular outcomes. There are some studies published post-transplantation. This is looking at SGLT2 inhibitors. These are all the prospective studies, and only one, the one in yellow that came from Trond Jensen's group in Oslo, was a randomized controlled trial. But again, these are all short-term safety and efficacy studies. There's a bit more focus on large multi-center randomized controlled trials looking at the use of SGLT2 inhibitors. So there's one which is currently recruiting in the Netherlands, and this is called the Renal Life Cycle Trial. And what this study is looking to do is to recruit from 3 different groups of kidney patients, those with advanced CKD, those established on dialysis, and kidney transplant patients with a GFR less than 45. And they are targeting a composite endpoint, which includes all-cause mortality, kidney failure, and heart failure-related hospitalizations. And they are looking to recruit 1,500 patients, and the study trial duration is for 4 years, but the trial is endpoint driven. So it will stop when they reach 468 composite endpoints. And the last time I checked online and chatting with colleagues in the Netherlands, they've recruited about 1,000 patients so far. And roughly, you could say 1/3 of them will be kidney transplant patients. And so hopefully they should be close to finishing their recruitment soon. So this will provide us with some information, and whether 500 patients will be enough to give us absolute clarity on post-transplant outcomes, but this is certainly the best that we will have just now. There is also another proposal which Arthur Matters from Minnesota is very keen to do, and there's been a lot of discussions about this trial called Renaissance. This will be purely looking to recruit from a post-transplant kidney transplant cohort, and the plan is to recruit 900 patients with a composite and hierarchical order of endpoints, which are mainly cardiovascular and renal. So this is something which will hopefully be submitted to the NIH, but will be limited to recruitment in North America. There's less prospective studies when you look at GLP-1 receptor agonists, and again, there's only one study from Norway, which is a randomized controlled trial, and it was really just looking at the physiological impact of a GLP-1 infusion. There's perhaps a bit more information with regards to retrospective studies, and there's a lot more information about the use of GLP-1 receptor agonists for its weight loss benefits to try and get obese kidney transplant candidates transplanted. Of course, there's a new kid on the block, and there's not much reported evidence with regards to this, although we are prescribing this to some of our patients. But I did find this abstract from the American Diabetes Association, and they had 16 solid organ transplant patients, of whom 5 were kidney patients who were started on tirzepatide or Mounjaro. No cardiovascular outcomes, but you can see it had some improvement to HbA1c, and as expected, it had about a 7% reduction in weight. So we do still need cardiovascular outcomes for these novel therapies, but the short-term safety and efficacy data is very good. And this was a study where we looked at our use of these agents at our very own center. And you can see that 3 years ago, things were, fortunately, I think they're much different now compared to what they were like then. There's still this heavy reliance on what are good glucose lowering therapies, but otherwise utterly useless for any kind of cardiorenal benefit whatsoever. And at that time, we had very few people on SGLT2 inhibitors, especially from a post-transplant diabetes perspective, but we did have a handful on GLP-1 receptor agonists. Fortunately, those numbers are now much better, and a lot of people have converted over from things like sulfonylureas to these novel therapies. And the reason why I think we should be using these novel therapies is that I think there's enough information about their short-term efficacy and safety in the context of transplantation. The cardiovascular outcome studies from the general population are so overwhelmingly favorable, and there's no real indication that that shouldn't translate over to our kidney transplant patients. And obviously, one of their big advantages are the overwhelming cardiovascular benefits that these therapies have for people with or without diabetes. And there are some trials in progress, but I always frown when people say, well, we need that trial. And then once that trial tells us the answer, we'll do it. But some of these trials will never, ever happen. And even the ones which are currently in progress, they're not going to report for a few years. And I think there's enough evidence out there to suggest that we should be using these agents, and we change our practice if the trials tell us something else, rather than waiting for a few years and not allowing our patients to benefit from what are fantastic cardiovascular disease lowering drugs. So I hopefully don't think anyone would find anything there controversial or upsetting, but a topic which certainly seems to raise antibodies for a lot of people is the idea of screening our patients, especially our asymptomatic patients, for cardiovascular disease to get them onto the transplant list. And this is basically where we are, and some of the epidemiology slides I showed you at the beginning. This is a summary of that. So we know the burden of cardiovascular disease is high for people on dialysis or when they're on the waiting list. That's the red line in red. Again, a successful working transplant lowers that cardiovascular risk in the long term, and a live donor transplant will be better than a deceased donor. But for most of us, we feel that there's an early high risk period for MACE. And even our UK data suggested that half of the myocardial infarcts we see in the year are actually seen in the first month. But in the long term, there is that benefit. So people need to survive that early high risk period to benefit in the long term from the cardiovascular disease lowering benefits of transplantation. So for most of us, we feel that the pre-op screening tests tries to mitigate this early postoperative risk. And so for many people, they feel that the argument in favor of screening is that it allows decision-making, informed decision-making between high-risk patients and transplant professionals about their risk. Screening may identify certain problems which we can intervene on, and these would be modifiable risk factors that improve early outcomes. And some of us may feel that screening is important because it excludes very high-risk candidates from a very valuable resource from transplant surgery, where they are very high risk of having a possible fatal event very early on. And I think this is the thinking for most centers in the world who do still continue with screening their asymptomatic patients. So what do I mean by screening? What do I mean by cardiovascular workup? That includes everything as basic from kind of history taking, an examination, looking at the ECG, and even getting an echocardiogram done. From my perspective, I don't really have an issue with most of these things. I do have an issue with echocardiograms, but my anesthetic colleagues seem to love them, and they are quite quick and easy to do. So I guess that it's reasonable for some centers to include this. I know that there are some centers who exclude echocardiograms from their very low risk patients, first-time kidney transplant candidates under the age of 40, for example. That was some guidelines that came out from the European Renal Association. My main bugbear, so to speak, is stress testing. It's the non-invasive cardiac screening, which often leads to angiography and then intervention. And you've probably already guessed, but I will make it very clear in the interest of transparency that I'm a strong advocate that we should abolish all of these. And I guess I will be biased in the evidence that I'm going to show you. But if you are interested in the pros and cons of this, there was a nice pair of articles which I contributed to for Kidney 360 with some kind of moderated comments afterwards. And I think they kind of give the two positions quite nicely. But I will try in my remaining time to convince you why I feel my position is correct. So firstly, the non-invasive testing, we know they are pretty specific, but they lack sensitivity for detecting coronary artery disease in our potential kidney transplant patients. And most of these studies are pretty historical, and this Cochrane review is over 10 years old. But the whole point of these non-invasive tests is that it identifies people who may need some kind of coronary intervention. But again, if you look at the general population, there's no evidence base that intervention improves any of these outcomes, whether it's death, non-fatal MI, unplanned revascularization, or angina. Now, one of the things that people often say is, well, look, this is the general population. This is not our kidney failure population. Our kidney failure population is different. And this is where ischemia CKD, which I'm sure you're all familiar with, this was the smaller study to the larger ischemia study. And this one was focused on people with advanced kidney disease, people with CKD stage 4, 5, or on dialysis. And they compared an invasive strategy with a conservative strategy with optimal medical therapy. I'm sure you're all familiar with the results. It was a negative study, so in the primary composite outcome of death and non-fatal MI and a slightly broader secondary outcome, there was no difference in outcomes between a conservative versus an invasive strategy. And even if you split the groups into different subgroups, whether they had diabetes or were on dialysis, no group showed any significance from an invasive strategy versus a conservative strategy. So there was no benefit, but there was risk of harm. There was a higher instance of stroke in the invasive strategy arm, and there was a higher instance of death or initiation of dialysis. When you look at that dialysis group, you can see that there was a significant group who were already on dialysis, and there was a group about 46% who were not on dialysis at that time. And what happened to them? Well, you can see that the group that was not on dialysis apart from the fact that they have no difference in their primary outcome, but they started on dialysis approximately 1 year sooner in the invasive group versus the conservative group. So no benefits, but all you've done is you've pushed your advanced CKD people for an extra year of dialysis. So does ischemia CKD answer all of our questions? Of course not. I mean, I think it's an excellent trial, but every trial, no matter how well executed, always has some unanswered questions. There's always the people who were excluded from the study. And again, this is one of the things that people often say is, oh, well, you don't know who's going to have left main stem stenosis. That's true, I don't. But I've got a response to that if anyone does have that as a possible question. Recruitment was slower, so the sample size did have to get a little bit reduced. But I think there's still suitable power to show that there's no difference in those outcomes. You could argue that certain subgroups may be more likely to benefit. In that subgroup that shows you for severe disease, you can see that there was a hazard ratio of 0.7, which wasn't significant, but you could argue that with a higher power, there may be some benefit from an invasive strategy in people with severe disease. But one of the main criticisms for ischemia CKD is it's answering a separate question. It's not specifically answering the question we focused on about kidney transplant candidates, and only 12% of the original study participants were waitlisted. But then this follow-up study was done where they updated the list of people who were kidney transplant candidates. So now there's 194 of those original 777 people. And same comparison, same outcome. So for people who are kidney transplant listed, they also do not benefit from an invasive strategy versus a conservative strategy. Again, there are people who feel that this does not fully answer the question, because being on the kidney transplant list is one thing. People who are actually going to have the kidney transplant surgery and the stress of the general anesthetic and the stress of the surgery, that's a different question. And that's the trial that everybody wants. Unfortunately, that is a trial which does not exist. The closest thing we have is this 2-decade-old study, the CARP study, which is looking at patients who got screening and intervention prior to elective major vascular surgery. These were clinically very high-risk people with either 1 or 2 vessel disease. But even 2 decades ago, before we had all this optimal medical therapy, you can see there was no difference in outcomes out to 6 years. So all of this evidence base has been absorbed by many of the guidelines, and this is the latest guideline that came out from the American Heart Association, and they acknowledged the clinical equipoise and the evidence base, which for me is quite clear that we should not be screening. But most of these guidelines do still advocate an element of screening. So for this particular guideline, they split their guidelines into kidney transplant candidates who don't have an evidence of coronary heart disease and those who do. And the first question we need to ask is, do they have symptoms? If they do have symptoms, well, then that's very easy. You refer them to a cardiologist. And even up to this point, I completely agree with this pathway. But if patients don't have symptoms, you can see that there's this very complicated flow, depending on whether people already have an element of coronary heart disease or not, and based on various other risk factors as to their pathway and what is a very long pathway to get people to a transplant list. There are many other guidelines. This is the KDIGO guidelines, which Greg obviously was part of as well. And I think these guidelines are also very broad, and they do recommend that we should be screening candidates who are high risk, but also that we should not be excluding those candidates from transplantation. And I think that final bullet point is completely correct. We do, at that point, we were awaiting further information. I would argue that some of this has already been answered. So I think ischemia CKD has probably answered that question about the utility of coronary revascularization for asymptomatic patients. The risks and benefits of screening for coronary artery disease at transplant evaluation. I mentioned that study has never been done. I don't think that ever will be done, and I'll show you why in a few slides later. But Bert Kosiski certainly looked at this as a power calculation over a decade ago, and even using kind of the high MACE rates that are seen in the US, you could see that it was going to be a very high recruiting trial, and this study never occurred. Then there's a separate question that, okay, you screen people for them to get onto the transplant list, but what about screening them thereafter whilst they are awaiting transplantation? And I'm sure many of you will be familiar with this, and you may obviously be recruiting to this in Canada. And this is the CASK study, which is still recruiting and is now extended out to beyond the original trio of countries, and is recruiting from a number of other places, including from here in the UK and Spain. But that's us. That's answering a different question. It's not asking about list screening before they join the list. It's looking at whether we should be doing surveillance screening afterwards. And I'm going to give you some real world examples of why I think being very aggressive doesn't change outcomes. So our friends down in West London, Imperial College, up until recently, used to have a very aggressive approach for their cardiovascular workup. Whereas we used to use non-invasive testing for people who were aged over 50 or who had diabetes, what Imperial College used to do was all these individuals would go straight to angiography and then possible intervention. And you can see that about half of their patients will fulfill that criteria and end up getting angiography, and then they may get some kind of intervention. And these were the people who were excluded from transplantation for a variety of reasons. And this is the patient's survival after coronary angiography, depending on whether people had any intervention or a normal angiogram. You can see that there's only one group who did poorly, and that was the group who were advised to have some kind of intervention, but chose not to have it. Now, Imperial for many, many years used to advocate that this was the best approach for cardiovascular workup. They were an outlier. They were the only center in the UK that did this. The rest of us followed a more standard approach of non-invasive testing. And my argument would be that if this was the correct approach, then Imperial should have better outcomes than the rest of us. And as you can imagine, that's not the case. If you look at the UK transplant registry data, looking at patient survival 1 year, 5 years after transplantation, there's absolutely no difference between Birmingham and West London. So what do UK centres do just now? This is a survey that we put out to the country. You can see that most are using some form of risk stratified screening. And there's very heterogeneous practice with regards to what criteria they use. Diabetes is ubiquitous, but then everybody else uses different things. So a patient who smokes maybe having cardiac testing in one part of the UK, but in another centre, they don't have to have any further tests. And again, you can see what investigations people are using. Probably very much depends on what the local preference, practice, and accessibility is. And there's variation with regards to how much cardiology involvement there is in the workup process and the listing and decision making, which you can see that for most centres is usually transplant surgeons and nephrologists, and less involvement from our anaesthetic and cardiology colleagues. All patients across these centres, there's experience of people not being listed on the basis of their screening tests. And you can see there was whole-scale enthusiasm for a clinical trial on this issue. We spent quite a little time looking at this, myself and a few colleagues with the clinical trials unit, even came up with a wonderful acronym for someone who's my scientific hero, Charles Darwin. And I think that comment, that quote from him, I think is very apt for this, because I think when it comes to thinking about cardiac screening for our patients, I think many of us use instinct or our cognitive bias rather than the evidence base and reason. And the reason why this trial is impossible is because it's going to be too complicated when you look at the pathway. And we need people to follow this green pathway, because not everyone who gets recruited is going to get listed. Not everyone who gets listed is going to have a transplant, and not everyone who gets a transplant is going to have an event. So you need to have enough people to have enough events. And as I've already shown you, 2.6% MACE events in the first year. I think it's 1.5 in the first 3 months. You would need to have a trial of probably over 12,000 people for this to show any non-inferiority. So it's simply impossible to do. The best that we have is this propensity score analysis. And this was done off the ATOM study, which was a large UK-wide study with linked outcomes. And what they did was they compared people who had screening and didn't have screening based on similar variables of age or smoking history. And you can see, again, there's no difference in MACE rates for people who were screened versus those who were not screened. Lots of caveats with the study, but the main one being that the high-risk patients were not included. Of course, if you had diabetes, there's no variation. You are going to have cardiac testing done. So what I've shown you is that there's absolutely no benefit, but there is harm. You can either delay the workup or you sometimes deny transplantation to people. There's the risk of contrast nephropathy, and as ischemia CKD is shown for advanced CKD people, you push them onto dialysis a year earlier. If people do get intervention and they're on dual antiplatelet therapy, apart from that delaying their transplant surgery, there's the surgical bleeding risk, there's the psychological burden, and of course, there is a significant morbidity and mortality associated with these things for our kidney failure patients. Of course, we're all tight for money, and we've had our budget last week, and we are even tighter than before. So there's the wasted expenditure, and of course, there's the unnecessary radiation exposure. So around about this time, I was a strong advocate that we should completely scrap it, but I am one person in a large nephrology team, and nephrology is one part of a large multidisciplinary transplant team. And to change anything, you need to have consensus amongst everyone. So we organized a meeting a few years ago with all the key players. My surgical colleagues were upset that I'd labeled them as the kind of treacherous Barzini, and we were the very cool Vito Corleone, but we managed to overcome that. And we were able to come with some changes. And of course, the other important team player in this, of course, is the patient. We needed to make sure that the patients understood what we were doing and why we were doing it. And I'll show you what's happened in Birmingham. This is what we used to do. So everyone used to get an echocardiogram in my view, and we used to repeat that as surveillance testing. And in the first instance, we changed it where we still got an echocardiogram for listing, but we do not routinely repeat this now unless there's a clinical indication someone has valvular disease and they need an annual surveillance, for example. The MyView rules were relaxed from an age perspective, and we do not routinely repeat this on the transplant list. And that was one of the reasons why we did not participate in CASC, because we've already made that jump and we don't do that. We're about to relax our age limit from 60. I'm pushing for 70. My colleagues are hinting that maybe we should do 65. And the one thing we introduced was a cardiorenal MDT for discussion of high-risk cases. And that's been wonderful for us. And we incorporate the DARSI questionnaire, the Duke Activity Scoring Index, and we use that as a scoring mechanism. And what we're hoping is that in time, we can start to slowly reduce our criteria, get rid of age as a criteria, hopefully soon, and then we'll start to focus on getting rid of diabetes as a criteria. So my colleague who runs the cardiorenal MDT, Charlie Ferro, always says, it's about having the right test for the right patient at the right time. I share an office with Charlie. I always tease him. It's all about having no test for any patient at any time. And what I often say is that I don't really care about someone's cardiac fitness. We should really be focusing on their physiological fitness. And frailty, I think, is far more important. And I run a complex transplant assessment clinic with a surgical and anesthetic colleague, and we have a lot of crosstalk with a cardiorenal MDT. So my vision is that we completely simplify this into something like this. And the reason for that is this was an editorial that was asked to write on the basis of those guidelines. And my feeling was that, what is the purpose of screening? And what are we actually trying to do? And what do we think it's telling us? And I think that's one of the issues, that for many people, they think it's giving us an answer when it actually isn't. And rather than thinking about kind of who to scan, we do need to think about why are we scanning? What benefit do we think these scans achieve? And this goes to the final bit where just what my philosophy is. And I always think that if we're going to do something, there needs to be a reason for do it, and what we're trying to do. And I think if we're trying to improve kidney transplant outcomes only, then yes, of course, we should cherry pick the low risk people, optimize our metrics, optimize our outcomes, but that will restrict access to transplantation. But if we think about the broader group of kidney failure patients, well, then the best intervention for them is a successful kidney transplant. And I think if we broaden access, we'll optimize outcomes for our kidney failure patients. And on balance of probabilities, I think will cause more benefit than harm if we have this laissez-faire approach to cardiac screening. And one of the worries that people have is often this kind of high risk period. This must be the most cited paper in transplantation. It's still used by some of my surgeons to my frustration. This was published in 1999. It's a 1980s US cohort. I was still kind of walking around in diapers, I think, in the early 80s. So we updated this using a UK cohort, and we found something astonishing. Within 30 days, there's a survival benefit in all patients. So either we've become amazing at our post-transplant care, or we have started to become very selective in who gets put forward for transplantation. And I think it's the latter that's true. Of course, if we're going to take risks, we need to have a supportive environment. We need very good guidelines, and the British Transplant Society, which I'm a member of, and on the board, we're working with the British Cardiovascular Society on guidelines on this issue. It's not just for kidney, it's going to be for liver, pancreas as well. And I'm hoping that the guidelines will be very supportive for people who wish to slowly reduce or get rid of aspects of their cardiac screening. Of course, a lot of this happens because people practice defensive medicine. But again, I would argue you probably cause more harm with these interventions where there's no evidence base. If one of your patients has a stroke after they have an angiogram and they were completely asymptomatic, if I was a lawyer, I think with the evidence base as there is, I would have a field day with that. And you can easily justify that clinically as to why you didn't put them through that test. And of course, we need to have the right regulation. We need to have our regulators supporting this kind of risk taking. I think in the UK, and I hope Canada is the same. We have a very supportive regulator, and I know things are completely different in the US, where there seems to be a slightly more kind of punitive environment, and I think that can become counterproductive. And it's all about what we're trying to do. If our focus is on trying to have the best post-transplant outcomes, if that reduces transplant opportunities, then that's the wrong outcome to be measuring. And finally, we did this survey looking at the multidisciplinary team and what they think about cardiac assessment. And you can see that the indications for cardiac investigations are so variable across the different units. And this was a survey that was filled in by the full MDT. And there's lots of reasons that people give with regards to why they do their cardiac testing, about equity of access or ownership, or indicators of cardiac fitness. But I think we disadvantage some patients more than others with cardiovascular screening. And Birmingham is a large multicultural population. We have a large South Asian population. They'll have more diabetes. They will get dragged into cardiac testing. And we talk about equality or equity. The reality for a lot of our patients is this: they've got so many hurdles to get to transplantation. And the best thing is that you just get rid of those hurdles and give everybody the same opportunity to access transplantation. But I'll leave you with two of these free text responses that shows you the disparity in opinion. And so this was a nephrology free text to say that there's no evidence base for any of these things, and patients are being disadvantaged. But then other of the MDT colleagues feel that this is all about decision making, and the cardiac assessment is a vital part of the overall kind of holistic assessment. So we do need to win over hearts and minds. But my personal opinion, if we go back to these 3 points, nope, it does not informed decision making. People can have fantastic tests and have an MI on day one. People can have the worst tests I've ever seen, and they sail through event-free. And we all have experience of those patients. Esteema CKD has shown us that you can't intervene and actually improve outcomes. And I would argue that what we are actually doing is we are excluding candidates from transplantation by reducing access to available resource, which will actually improve their cardiovascular outcomes. And this is rationing by any definition. And you can be bold. And one of our centres in the UK has been very bold, and that's always Belfast, who always push the boat out. So you can see before 2015, they had a very standard cardiovascular workup, just like anybody else. And then after 2015, they changed to what I propose we should be doing, where symptomatic people are seen by the cardiologist, but everybody else simply gets ECGs and an annual Duke activity scoring index. And what they've shown is what I think are very acceptable outcomes. These are probably double the rates of what we had in our English study, but very few fatal events. And if you scrap cardiac testing and you double your MACE rate, I think on balance, that's far more beneficial for our patients. So just to summarize, cardiovascular complications are a leading cause of morbidity and mortality. And I think the evidence base for risk reduction post-transplant is sadly not as good as the general population, but we should be doing lifestyle intervention. We should be aiming for the same metrics and outcomes, and we should be using more novel agents. And don't wait for the trial evidence. Some of that will come in years, some of that may never come. And I think I've labored enough on why I think we should not be screening our asymptomatic kidney transplant patients. So why is this all topsy-turvy? Well, we have evidence for doing something post-transplantation, but we don't do it very well. And pre-transplantation, we have evidence for not doing something, but we still carry on doing it. And my personal feeling is that we should let more high-risk cardiovascular disease candidates through, and we balance that by optimizing their post-transplant care with the best evidence base that we have. And with that, I'd like to thank you for your attention. That is a picture of the university at the front and the Queen Elizabeth Hospital. You can see those three strange kind of alien pods in the background. And happy to take any questions. Thank you.
Fantastic. That was a really wonderful overview of the topic. There are many transplant nephrologist colleagues in the audience. I'm sure they'll have something to ask. But if I can ask a diabetes question, since you have done research in that area as well. I think my transplant nephrology colleagues are moving towards using flozins and GLP-1 RAs, but there is some reluctance, right? For example, the ACE inhibitors work in the general population, but as Greg's trial showed, the evidence in post-transplant is not there. Maybe the pathophysiology is different, right? How do we know these drugs will have, A, how do we know these drugs will actually work? And B, is the side effect profile. Maybe the genital infections, UTIs are a bigger concern in the transplant setting, or maybe, the GI effects of the GLP-1 RA, they're already on CellCept, all those things. How should we think through about that in the lack of trial data?
Yeah, no, man, that's the difficulty that obviously we there's so many things that we can take from the general population, but they've either not been tested, or when they have been tested, we end up with these kind of negative studies. And even after Greg's study, I think most of us we still do use round pearl and things, but we kind of just do it with a not quite with the same bounce in our step, because it would be lovely to kind of say to patients, well, look, there's evidence that this will be beneficial, but it still feels like the right thing to do. No, I mean there is still reluctance with regards to the novel therapies, and especially you're right, the SGLT2 inhibitors. There's short-term safety and efficacy data, but we don't know in the long term whether they have the same benefits. And maybe the renal life cycle study will show that. What a lot of people tend to do now is they try to avoid the use of SGLT2 inhibitors in that very early period. A lot of my surgical colleagues do use ureteric stents, and there seems to be a reluctance to use SGLT2 inhibitors certainly for the very early few weeks, when we would avoid using ACE inhibitors and ARBs as well. But a meta-analysis that was published, which looked at the rate of urinary tract infections, showed that actually there was very little difference. I think that's the thing which worries a lot of us. Our personal experience has been that there's not been very much difference, and we, for example, for a lot of our recurrent IgA nephropathy patients, we've been giving them combined kind of maximum ACE inhibition or ARB with an SGLT2 inhibitor. And we've not noticed any kind of major concerns. We do give them sick day rules, of course, and we are very clear with them that look, there's no hard, firm evidence base for this post-transplantation, but this seems like the sensible thing to do.
Excellent. Any other questions from other folks? I think we are, as far as the cardiovascular screening is concerned, I think we are similar. I think we screen for, over 50, diabetes, smoking. They get seen by our cardiology colleagues who mostly ask for a perfusion scan. Though, again, I don't know if you feel that maybe we should get rid of that as well, eventually.
So we only now screen for people who are aged over 60 or have diabetes or have asymptomatic but some kind of underlying cardiovascular disease. And we raised the age from 50 to 60. We've never done smokers or anyone else. And I was very keen that we just went cold turkey and we stopped it all. The feeling at that time in our unit was that I think everybody agreed, and this is the important thing of having everyone in the one room. And because we always used to kind of moan to the surgeons, "Why are you insisting on these scans?" They'll say, "Oh, it's because the anaesthetist will not gas them without it." So then we moaned to the anaesthetist, and it says, "Oh, it's because the cardiologist." So we thought, why don't we all just get together and talk it through? And this was in the post-ischemic CKD environment. The feeling was that we can't go cold turkey like Belfast did. Belfast is a much smaller program. It's a very different cohort. Um, and what we would do is we would do it in incremental steps. And so, I mean, the one thing we did stop completely was the maintenance. We would do a routine myoview if somebody had been on the waiting list for a long time, but that has completely gone. And what we feel the safest option is to kind of do it in incremental changes. But the one thing I always say to my colleagues, it's only a matter of time before someone who we did not test and we normally would have tested has a MACE event. And that is the point where you do not lose heart or faith. That is inevitable. And if we do enough transplants, we have to have complications. If we're not seeing complications, we are either not doing enough transplants or we are cherry picking very low risk patients. So luckily, we've not had that wobble yet. And therefore, we will be looking to raise our age and then slowly, I think age probably will be okay. I think stopping screening in people with diabetes will be will need some convincing of hearts and minds.
Yeah, yeah. I mean, there are the stories, right? I still remember my dialysis patient who had a MI first day post transplant, ended up
Uh,
getting an emergency cabbage, and kidney never worked. But we should not let those stories sway our.
well, so I sometimes have these slides which always used to upset some people, but I used to talk about cognitive bias and why I said, I would talk about, look, I've shown you all this high grade systematic review, meta-analysis, RCT evidence, but your decision making is influenced by something which is not even on this scale of evidence basis that n equals 1. I once had a patient who had a heart attack, and therefore I'm going to subject everybody else who I see, man, woman, child, animal, to cardiac testing. And that is, I think that is the wrong approach. But I mean, we are only human, and I think our personal experience does often scar us. But I think, yeah, that n equals 1 is, I think, is the reason why a lot of people, because we all have those stories. But I mean, I look at it differently. I think you need to have complications. If you don't have complications, then, if we just select non-diabetic under 40-year-olds for their first kidney transplant who are white and live in an affluent area of Birmingham, we will have 100% patient and graft survival. And we'll, tick all the boxes for excellent outcomes. And everybody will ignore the fact that we've left all these other people who, by and large, will benefit from transplantation without that opportunity.
Absolutely. Oh, the conference room has their hand up.
Okay. Hi, that was an excellent presentation. I'm one of our transplant nephrologists, and I think that our practice here very much mimics yours. We're non-invasive testing patients we deem high risk. I do 100% agree with your approach. I also wonder about the repeated testing. I think that's one of the struggles. Two comments. One is, we do have this cohort that, it's difficult to say that they're asymptomatic because they just don't exercise enough, right? They're very frail, and they don't actually put themselves through a stress test. Their best stress test is that they go to dialysis 3 times a week, but they're very immobile. They can walk less than 100 meters, and we're considering them for transplant. So maybe that points to your question of frailty. My next point, and this is going to be controversial, and I'm just being a jerk and a bit Trumpy today about it, but we effectively only list 20% of our patient population for transplant, and it is still a very limited resource. And so until we have pig transplants for everybody, we do kind of have to make some decisions about who our best candidates are and who is going to maximize the longevity of our graft. So even if we don't agree with this, is this one way that we should be using to maximize our kidney potential, i.e. eliminate those frail patients or those ones that we don't think are going to survive long enough? So I know that's a jerk question because I don't agree with that, but you could make that argument.
No, I mean, two excellent questions. I love controversial questions. So the first question, I mean, you're absolutely right. And that's probably one of the main things that people will say is that a lot of our kidney failure patients and the hemodialysis patients, they simply don't exert themselves enough, apart from, you're right, dialysis. And that's one of the reasons why we set up this complex transplant assessment clinic, because the problem is sometimes you see a very frail person who's very immobile, but their cardiac investigations are going to be absolutely fantastic, but you still feel that they are not a suitable kidney transplant candidate. And what we will often say is, if someone is too frail to even exert themselves, their frailty is the main barrier to transplantation, and it shouldn't be their heart. And the Darcy score is fantastic, and there's good evidence base for it. But again, it is very subjective. So what we do for our listing clinics now is we are actually getting them to do like a sit up and go test, or a 6-minute walk test, so that we have something a bit more objective. With regards to the second question, yeah, I mean, I guess it all boils down to our philosophy, and I completely agree. It's simple economics. There's a supply versus demand issue. It's a valuable resource. We should give it to people who are going to have the best chance with it. On that, as a response, though, I will give 2 points. One, that's perfectly fine, but then we need to be honest with our patients that we are rationing their access. And there's a health secretary in the UK, former health secretary, who's slightly maligned now as a politician, but he was health secretary in the 60s, and he used to say that the worst form of rationing in healthcare is when you don't actually tell patients that there is rationing, because the whole point of rationing is that people need to be very frank about it. So if that is what we're doing, then we need to be very honest with patients. But the second point I would make is, that's true. People with very high cardiovascular risk will have worse outcomes post-transplant than others. But then I would argue, well, there are many other groups of people, if you dichotomize them, where they will have worse outcomes than others. So older people are going to have worse outcomes than younger people. Should we exclude older people as well? People with diabetes are going to have worse outcomes. People from socially, economically deprived areas are going to have worse outcomes. People who are not white are going to have worse outcomes. Where do we draw the line? Why single out high cardiovascular risk people? Why not say, right, everyone over the age of 70, you're not going to live as long with your transplants, so we'll just stop you guys getting transplants. So I think the point is very valid, and that is one of the points that people make. I personally think that's a slippery slope. I think if we're going to single people out, then where do you draw the line as to who we single out?
Excellent. I think we are at the end of the hour. So thank you again, Professor Sharif, Adnan. Thanks for that wonderful overview and your passionate argument, as always, to transplant more. I think we are on the same page that transplant is the best management for cardiovascular disease in dialysis patients. And on that note, I hope we'll relax our rules as well. I think we are a little bit conservative still, but less so than Imperial and the Americans, I guess. So this has been recorded, and for the others in the audience, you will be getting a survey in the mail. So please complete our evaluations, and I hope to see you in person at some conference.
Fingers crossed. Hopefully 2025. Thank you, everyone.
2025.
Pleasure,
Thank you.
pleasure talking to you.